We want to inform because informed EMS hopefully makes us an innovative and adaptive EMS.
We know that there are perverse incentives in healthcare to do things that don't make sense for the patient. The creativity, the opportunity to solve the puzzle is there for those that want to lean in now. Now is the time.
There was no barriers, no impediments, no red tape, no government, and it was just all about healthcare. What would be the one thing that Eric Beck would do?
I wish that we paid for outcomes.
Well, welcome to another episode of the Leadership Lab, and I am back in studio with Dr. Eric Beck with ESO. He was our inaugural guest, and a lot has happened, Eric, since we talked last in some of the stuff that you were talking about, and we want to talk about that today. We want to inform because informed EMS hopefully makes us an innovative and adaptive EMS. And so let's kind of talk through some of the things. I don't want to rehash. People can go to that first episode and kind of listen. We kind of did a really good job giving a foundational principles of what we've been talking about for many years now, well over 2 decades. And there's a lot of traction that is being made now. And so we're going to talk a little bit about this, talk about some things that maybe some people that are listening to this day may not be aware of and will become aware of. And so that's kind of why we're doing these type of podcasts. So welcome.
Glad to be back.
Glad you're here. So the first question that I want to get, and we're going to just kind of dive right into it for our audience, is I want to really talk about value-based outcomes as well as payment reform. We didn't talk a lot about that when we first talked. We talked more about the data, the outcome of the data. I think everybody's agreeing now that absolutely we're ahead of the curve now. We actually can sit, I'm going to call it at the big boys table. We have data in EMS that we can really show that now begins to impact it. So let's talk about how we use that, what that looks like to create, to kind of reform our payment system and what some of that stuff might look like and some of these new things that are coming.
Yeah, absolutely. I think data and outcomes are at the center of any policy or reimbursement conversation. And fundamentally, it's about value. You use that word. Value is always in the eye of the beholder and oftentimes is population defined. When we talk with those at the federal level, they're very interested in the Medicare population. They're very interested in the Medicaid population. When we talk with commercially insured, it depends upon their line of business. And so understanding the population lens is important. That helps us understand the denominator of the individuals that are going to be of interest as we look at the data. The second piece is really to understand what quality metrics influence the outcomes of interest for that particular population. And if we think about quality measures as process measures in care delivery that we know through the evidence reliably influences those outcomes, that's the real crux. So measuring the right quality metrics that help us establish which care delivery processes will reliably influence the outcomes of interest to a payer, as an example, allows us to crosswalk the care to dollars. And fundamentally, EMS has been reimbursed for transport, for level of service, for mileage, none of which are clinical in their context, none of which are easily linked to quality. Said a little differently, I think the opportunity for us is to look at the conditions that EMS has demonstrated quantifiable impact in their communities. Let's think heart attack, STEMI. Let's think stroke. Let's think trauma care as a couple of examples, some of the most mature examples in the EMS system. We know that EMS saves lives. We have outcomes that can be demonstrated. But we need to link that back to the quality metrics and to the process delivery metrics that really substantiate EMS's contribution to that outcome. That attribution, that linkage is really what allows us to have an informed conversation about reimbursement reform.
And I think that the way that you're talking about it is we're being very systemic about it. And we're looking at it through a lens of to ensure that EMS continues to be sustainable and functional in the communities it serves, but also that it adapts to the current environment and that we don't continue to operate in an environment of 40, 50 years ago. And I think the healthcare in general is trying to adapt to this right now. And I believe that we talked a little bit about this. This was before we were opining in our first episode about what the One Big Beautiful Bill was going to do. Well, that has subsequently passed. And we've had other subsequent episodes about the One Big Beautiful Bill, while maybe not with you yet. But I am going to reflect on a podcast that I just aired with Dr. Lisa Graybear, who's a healthcare economist. If you have not listened to that, strongly suggest that you do. But she brings out some things around this Rural Stabilization Fund. And I believe we have a lot of opportunity to demonstrate the value that EMS brings to not only rural healthcare, but that how it can be even demonstrated in the urban areas through maybe the Centers for Medicare and Medicaid Innovation, which doesn't really need to rely on the Rural Stabilization Fund. And I'm bringing this up for a reason, because many times with these models that we've been talking about for the last 20 years, we've been demonstrating, it's not like we haven't been doing it, but it's been anecdotal, and it's generally been with the payer market. And so, but we all know that the Medicare market is the largest portion of members that the EMS community serves right now. Medicaid is a strong second to that. And so the One Big Beautiful Bill started to pick apart the Medicaid portion, which is actually probably where we should have been. And you and I talked about this on episode 1. So let's talk a little bit about that. And I'm going to talk about a controversial statement that Lisa made when I asked her, what would you do from your background being in CMS, working for the American Hospital Association, working for Ways and Means at the time, and now you're a healthcare economist and a professor. What would you do with that? Her first statement was, if she could look at it in priority, was to say the majority of the money should be distributed to the 10 states that did not expand Medicaid, which I found very interesting. Because her reasoning behind that was, technically, the states that expanded Medicaid have been getting a 90% federal share on the expansion population since 2014. Which that was a very interesting thought. Not that I agree one way or the other with it, but it was a very interesting concept. And then she made another very statement that I'm sure made all of our hospital friends happy, that none of the money should be given to the hospitals. And so I'm not going to ask you to opine on that, but it was very interesting from that perspective that how can EMS insert itself in to this window of this healthcare continuum that we talked about? This actually something that you penned, unplanned, unscheduled response. That's the continuum. Not saying we can't do other stuff, but focus industry, unplanned, unscheduled. How can we participate in that?
Well, you said a number of things there that are controversial, and you don't steer away from those. I appreciate that about you, Asbel. First observation from your comment and question, I think the state lens is really relevant for EMS. EMS is regulated at a state level, and Medicaid is administered at a state level. And so there's a nice alignment there in terms of how to think about bringing strategies to bear at scale, bring the rural stakeholders, rural hospitals, rural EMS systems together, linking them with urban centers and larger metro EMS delivery systems. So I want to call that observation out because I think that is
very critical. I'm glad you did.
I think that's a really important alignment point. I think the second item that you mentioned is that we know the Medicaid population in particular uses the EMS system, uses the 911 system, uses emergency departments disproportionately compared to other populations. Medicare is right up there. And so, there is a unique alignment with those populations, back to my earlier comment. We know that that is a group that has a higher chronic disease burden. This is a group that has substance use. This is a group that has behavioral health related issues, all of which are featured in the legislation. And so huge opportunity to think about bringing those together. CMS has also talked about improving the beneficiary experience, particularly around emergency department boarding. We know that the longer folks wait in emergency departments for hospital admission, et cetera, bad things happen. It's not a safe way to provide care, particularly in overcrowded emergency departments. We know there's delayed ambulance offloading. There's a collection of issues that are fundamentally at the nexus of EMS and hospitals, and it's true across the country. And so that, I think, brings into focus several opportunities for EMS to think about where can we uniquely add value. So we think about the patient populations we serve. We think about the Medicaid and the Medicare population specifically. We know that there is a segment who utilizes the 911 EMS system frequently. And those high utilizers can now be identified reliably. There are many examples of successful programs going on around the country that have been going on for a decade or more with reliable outcome data. And that is one opportunity. We have a second opportunity around how we better identify those folks using the 911 system and are not well served by an emergency department. In fact, they might be better served with other resources in their community. We touched on this in the first episode, but how we connect those people to the appropriate resources is fundamentally linked to the reimbursement mechanisms and the incentivization that exists today under Medicaid and Medicare reimbursement policy. And so that's a second opportunity. The third opportunity is what we were just talking about, our traditional origin story, time-sensitive emergency conditions, stroke, cardiac arrest, trauma care, heart attack, sepsis emerging as another example. How do we really demonstrate what we can do as a clinical provider contributing to the outcomes that matter? And that generates value not just in terms of the clinical outcome, but also there's financial benefit to a variety of stakeholders, including the hospital, including Medicaid, Medicare, and to the patient as a consumer. So those are three examples of how, in the context of the current legislation, we can really think about opportunities that are well aligned with EMS value creation, with where we have data, where we have outcomes, where we have evidence to demonstrate EMS's contribution to improving outcomes for patients.
So let's get into some specifics, and I'm going to kind of put you on the spot here. And right now, what we do know is that this $50 billion fund, the way they plan on distributing it is like equal measure to the states, but then additional based upon the way the states and the aptitude that they need those funds. Now, whether that's the best methodology to do it or not remains to be seen. I think there could probably be some things that are tweaked around that because, technically Maine gets kind of the same amount that the state of Texas does, and the population's different. And so, me, I can say controversial statements, but to me, the methodology, in my personal opinion, probably needs some looking at. And we were with a U.S. Senator on Sunday that kind of indicated something similar. So I know there's probably going to be some congressional, not pushback, but maybe guidance to the administration on the way that methodology is. So based upon if they use that current methodology, the question that I'm getting a lot of right now from different people from different states is, what should we be doing? What should we be getting to the table? I was talking to someone this morning. I'm meeting with several of my state reps and senators and a member from the governor's office. And this was a state on the East Coast. And what should I talk to them about? And so people need some guidance, or what usually happens is we go to the table and we don't really know. We anecdotally say something. We may not have data to back it up. And so then what happens is our best intention gets pushed to the side because we don't have the data. So I know this has been something we've been working on. And I know this is something that you've been working on for many years. And so can you give just some guidance to people that are listening today on what this looks like as we start putting together a blueprint on what people should be doing? Because things are moving pretty quickly.
Yeah, I think the first thing is a truism that is timeless. And that is, there is no new money available, no new dollars in healthcare. And so asking for more, asking to increase your reimbursement is a non-starter in a conversation about reimbursement and how EMS can participate.
And I personally 100% agree with you on that. And I think that needs to be said. We keep saying that, but I just want to make sure that everybody hears that again.
So again, asking for higher rates and reimbursement is a non-starter. The question really needs to be grounded in value and in outcomes. And that's what people pay for. That's what can be monetized inside of a insurance or a payer conversation. And so, the first thing to do is to ask yourself, ask your organization, are we able to measure outcomes reliably for all of the patients that we care for? And of course, there are those we transport and those we don't. There are those that we have quality measures around and those that we don't. But, starting with that as a simple lens is to get organized with your data, make sure that you've got an outcome story that's cogent, and understand that that's where the conversation is going to start. It's not going to start with asking for more money. Once we have data and outcomes that are of interest to the stakeholders, the conversation is about how do we align incentives so that we can generate value for other stakeholders in the healthcare ecosystem. And again, that comes back to understanding how those quality metrics and process measures reliably influence the outcomes that translate to dollars that are going to inform that conversation. When those are aligned, we can actually create win-win-win scenarios. A win for the patient because they're getting better care, more appropriate care, higher quality care. A win for EMS because they're getting reimbursed fairly for the care that they're providing. And the third is that it helps to save money downstream. We know that patients who get appropriate care in time-sensitive emergencies, as an example, have better outcomes. Better outcomes translate to lower costs. For example, a stroke patient who gets recognized in a timely fashion by EMS, gets their pre-hospital bundle, goes to an appropriate receiving center for that suspected stroke, gets appropriate stroke care by that hospital, and goes on to recover and care for themselves, et cetera, costs much, much, much less than someone who goes unrecognized, who has a catastrophic outcome, has lifelong morbidity, is unable to care for themselves, and ends up costing Medicaid and Medicare millions of dollars over time, right? So just as one example, and we know that care begins at the 911 call with appropriate recognition and continues through first response, through on-scene care, care provided in transport, the transport itself, and then our partners in care at the hospital. That entire system of care is a beautiful example of how our clinical and quality contribution directly influence outcomes that are directly tied to different cost trajectories for a patient.
So here's what I want you to do. I want to give you I want you to give an example, and I'm doing this for a reason because I've had this conversation. I've used this example that you have actually given me because we were able to break it down because we were talking about stroke STEMI care, and they were like, "Well, hang on, wait a minute. That's not a lot. That doesn't make up a lot of our call volume." And you actually gave a piece, and they're like, "Huh, we never thought about that." I was actually talking to someone at the federal level in this same exact example, and so I want you to give this for our audience because I don't think we've talked about this before, but I want them to understand the strokes to me because there is a huge downstream cost to that generally speaking, EMS could actually impact. If we really understand when we talk about the outcome of it, it begins to make sense. And every time I explain it, people have these aha moments. So I want the people that are listening today to have those same aha moments. Can you give that example that you gave about the strokes to me and what y'all's data has shown?
I can, and we'll stay on stroke because it is such a powerful example. And to your point, while it may not be the highest frequency call, it is a condition that is so influenceable by the care provided by EMS. And we find things like ground level falls are distractions. We get concerned about the fall, we get concerned about traumatic injury, et cetera. That takes us away from keeping stroke on our differential diagnosis. They don't necessarily get the pre-hospital stroke exam. And of course, we know EMS can set in motion all sorts of diagnostic momentum in the emergency department. And so what EMS does in the field, how they're influenced even from the 911 call, set in motion an entire sequence of events that have tremendous consequence.
Especially when we see it now in the longitudinal data. And that to me was so powerful. And it has been a powerful point that I've been able to make outside of our industry. Sometimes our industry didn't understand it until we started talking through it, from the diagnosis that come back from the hospital and that it was somebody that actually fell and you treated it incorrectly versus it was actually a stroke. And if we would change that, like that to me is if we could even make a 50% impact on that 50%, it's pretty substantial to what that can do for the entire healthcare system. So it's an important point to note, and I wanted to spend some time on it because people need to get their thoughts moving that way. As we talk about, these are high acuity patient, maybe low utilizers, but they impact the entire healthcare continuum because we have to see EMS, we have to see healthcare for EMS through the healthcare continuum lens, not through the EMS lens. And that's really, really hard for us. And that's why we keep talking about it.
Well, and that's why I think outcomes are such a powerful focus point for us, because healthcare cares about outcomes.
Yeah.
The rest of healthcare is outcomes oriented. That's how they're judged. That's how they're scored. That's how they're reimbursed increasingly. And so outcomes becomes, no pun intended, almost the interoperability point for us to understand our value relative to those other stakeholders in the healthcare ecosystem.
Okay, so I'm going to kind of pivot here, and I'm going to change subject just a little bit. We're going to move more onto the federal Medicare platform. We've talked a little bit about the One Big Beautiful Bill, the Rural Stabilization Fund, now that it is passed, how that can be impactful. And just recently, of course, there was an executive order that Trump put out. Trump has put out more executive orders than any president in modern times right now. Some have been controversial. Some have liked them. Some have not liked them. I'm not here to opine on that. But there is one executive order that he did put out that was really a discussion around healthcare. Mm-hmm. And so recently, Secretary Kennedy, which is the Secretary of Health and Human Services, as well as Dr. Oz, who's the CMS administrator, have actually put out a notice that they are going to put together a federal committee, or what we call a FACA committee, that is going to advise CMS and HHS on some key components. And so for you that are just hearing about this, because the industry is kind of waking up and hearing about this, I'm actually going to read exactly what this committee has been formed for. It is to do this. It's to focus on policy initiatives for chronic disease prevention and management. It is to reduce regulatory burden while increasing accountability for safety and outcomes. Advancing real-time data systems for claims, quality, and performance. Improving care for Medicaid's most vulnerable populations, and ensuring the sustainability of Medicare Advantage with modernized risk adjustments and quality measures. That is a lot, and it's going to require certain skill sets. And so there's a committee, you got to submit for it, apply for it, things like that. I have a few questions for you, and spend some time reading those objectives, because if you're listening, and especially if you're listening from the EMS industry, there is a lot there that's impacting. If you're listening to healthcare and you think Medicare Advantage is going away, that's probably an interesting comment. Go back and listen to Dr. Lisa Graybear's podcast that I did with her specifically about Medicare Advantage too. But it's not going away, which means we're going to have to get around quality. We're going to have to understand that piece of it as well. So why does EMS? Now, you probably aren't controversial. I have no problem addressing it, so I'll do it for you. But I want to know from your perspective, why does EMS need to be at this table?
Well, we have a point of view on almost every one of those objectives that you mentioned. And while we were built for emergency care, a lot of what we do is not emergency care. And on one end of the spectrum, we have programs that are providing preventative care and chronic disease management. In the middle, we have a variety of programs targeting those high utilizers. We also have other programs that are built around very specific community needs, particularly in rural or more austere parts of the country. And so our perspective is highly relevant to those discussions. We're called to care for members of the population, particularly some of the most vulnerable, oftentimes Medicaid and Medicare beneficiaries, sometimes dually eligible beneficiaries who are falling through the cracks, who are not well served by the existing delivery system. And so that point of view is so incredibly relevant to how we create durable, transformative solutions for that approach. Two, I think what's really important is the longitudinal perspective that you mentioned. And this is new for EMS, being able to look at an individual over time in the EMS data with outcomes, not just looking at individual transports, individual encounters, but that longitudinal perspective. And so to kind of connect the through line from our chat today, we're going back to looking at populations, looking at outcomes, looking at quality metrics around individuals over time and around populations of individuals over time. And that is a perspective that is unavailable in the claims data today. So, historically, claims for EMS include pickup address, a drop-off address, an allowed amount, some mileage, a level of service. There's nothing clinical in that data, Asbel. I mean, you're the expert on ambulance claims. I shouldn't be telling you what's in them. But there is nothing in there to inform a policy discussion. And so all that happens upstream of the emergency department, all the care that's being provided by EMS, completely invisible today. Interfacility transport, critical care transport, moving patients from rural parts of states to urban centers for tertiary and quaternary care, aeromedical transport. All of this is connected in the same way. It is invisible from a clinical lens. And EMS is unique in that we provide such a high degree of clinical care that can really change the difference in the clinical outcome and the cost trajectory. But the data available to the insurers, to Medicaid, to Medicare includes no clinical data elements. None. I mean, that is the opportunity, is to help be at the table and help provide that perspective and to advance a different set of discussions. We gave a couple of examples. And, the rural parts of the healthcare system, both the hospitals and the EMS systems, are under incredible pressure. Workforce pressure, reimbursement pressure, sustainability dynamics, longer transport times, dealing with low acuity calls, high acuity calls. That is a prime opportunity to really rethink the model.
Oh man, you've said so much, and I just have a lot that I want to talk to you about here. There's 2 points I want to hit in on. One is, and I agree with you, we need to be at the table for a myriad of reasons. One is in the claims encounter data that we're not doing. And this was a test. ET3 was kind of a test pilot to even get a portion. Like there were certain codes with certain modifiers needed. And it was very, very problematic to some systems to be able to even do that. There were some systems that just decided not to participate in ET3 because they could not get that piece of the treatment in place put together as the connector. So there's some challenges that we need to have somebody that has the acumen, that understands data, that understands the clinical side of things. And so we need to be strategic as an industry. If you're going to advocate for someone for EMS to be at the table, we need someone that understands EMS. So it's going to have to be somebody that talks to the clinical side, Eric, that talks to the data side, that talks to even the payment side of it, to understand a little bit about what happens in that sector and how do we do that and how do we marry the two. But I'm just saying, as we kind of build that up, we need to be talking through what skill set and expertise do we have that we put together for that. That's number one. Number two that I want to just dig into, because you said something here about outcomes and the quality of the data, is to expand upon just a little bit about what the industry needs to factor in of marrying the payment side of it, like when we send a claim, to the outcome. In your mind's eye, what does that look like? Because other systems are doing that to payers, but we don't do that. So give me a little bit of feedback on that.
Yeah, I mean, I think when we think about claims in EMS, we think about generating a fee-for-service reimbursement opportunity for a transport. We don't think about understanding total cost of care. We don't think about quantifying the financial impact that comes from the outcomes EMS delivers. We don't think about the quality metrics and how those influence the expenditures on whose ever P&L, whether it's the commercial carrier and their commercial line of business, or whether it's managed Medicaid, Medicare Advantage, et cetera. And so this is a new space for the industry. I, go back to, earlier chapters in my career, taking full risk in innovative EMS models, taking risk with physician practices, running a large ACO in a health system. The rest of healthcare has been on a journey for a long time. And CMMI, CMS have put together a variety of programs to help them learn how to use claims data as part of the learning that's required to improve not only clinical outcomes, but also to drive improvement in financial outcomes. And we know that there's a high correlation between better clinical care and lower cost. We also know, and we need to be honest with ourselves, that there is significant waste in the emergency department, waste in low acuity activity that the emergency and 911 system was not originally conceived for. And again, we don't serve the patients well clinically or otherwise when we don't have those honest conversations, looking at the data, looking at the outcomes, understanding the cost impact. So that to me is really where we need to continue to focus. And a longitudinal perspective, a patient level perspective, and a population level perspective are what's required to do that.
You worked for a hospital system too, is that right? Didn't you do something with the hospital system? It was a hospital system in Ohio, correct?
Yep. Yeah, large academic system. We had rural critical access hospitals, and we had large level 1 trauma centers and children's hospitals, kind of the full gamut of community, academic, and rural.
So you have that whole perspective, even from the hospitals in EMS now, and now you're with the data company. There's been something interesting that I have seen, because you're the CEO of one of the largest EHR companies for EMS, specifically in the world, I think, for the most part. Tell me a little bit about, because you've been doing some new hires. You've been hiring a lot of people almost from like Silicon Valley or what have you. Can you give us a window into what your strategy is there?
Yeah, we've been on a journey for a number of years. I've been with ESO for over a decade, previously as a board member, and have always been compelled by the mission to improve community health and safety outcomes through the power of data. We now have amassed a really important data asset. We're entrusted by a number of partners in the industry to use that data for good, and we've published over 180 scientific and peer-reviewed publications. We're now at a place in which we can put that data to work to help inform some of these really important discussions for the industry around innovation, around reimbursement, around outcomes and quality improvement. From a technology strategy, we have always called our EPCR an EHR intentionally. And that's because we had a long-term vision to create a longitudinal record, one that looks at Asbel Montes over time, not one transport at a time. And understanding you more holistically through interoperability with hospital outcomes, with HIEs, with a variety of partners in care, because that's really what providing healthcare is all about, and to understand that context. And so the next step in our journey is being able to partner even deeper within the healthcare ecosystem. And that includes so many partners that have historically not been at the table with EMS. It's an opportunity for us to leverage, practices that have been used in other parts of healthcare and in other industries for a long time. So we hired a new CPTO who joined us from Google Health and brings a lot of expertise around healthcare data and how we think more holistically about those data sources. We know that AI is an unbelievable technology that can be leveraged for good. We're early days. We know that there are risks around using that tool and technology. And so we're braving some new territory to help drive efficiency and to do that in a way that's responsible. Closed systems, secure data, making sure we're not introducing bias while we're also aspiring for something much greater. How can we really transform the industry by changing the way we think about how we do our work, starting with the outcome first, and then working upstream to think about new ways that we can take care of our communities, take care of individual patients, generate value for stakeholders across the ecosystem. So I'm really excited about what we do every day. This is personal for me, having started in the industry as a paramedic and firefighter. I still practice clinically in the emergency department, and every time I see a patient come into the emergency department, particularly if they received a transport for something that was not well served by the emergency department, I'm reminded of the work that we need to do as an industry.
And that's a good segue into where I'm going to move next. I keep saying we're in a era of protect and preserve, and that's going to take you down one road, or adapt and innovate. That's going to take you down another road. And I was talking about this with some colleagues last week, just relative to what we're seeing in this administration. We're 7 months in, and they're moving very, very quickly. And generally, healthcare has had a hard time moving quickly. And I get it. Patients are the center of everything that we do. So we need to make sure that any type of pivots that we do, anything like that, that there's always some type of fail-safe there. And that was a part of the Rural Stabilization Fund, was really like, if we make dramatic change like this, we need to make sure there's not an impact in a rural community. And that's why they put the Stabilization Fund. So let's talk about that from EMS sustainability. That's what I hear all the time. I see some people, they're excited. Great, let's move, let's go. And then I've got some that are like, oh no, this is going to decimate this. I mean, it's feared. Chicken Little, the sky is falling. And I've been around doing advocacy for 20 years now or more. I've been doing healthcare EMS finance for 29 years. And the 20 years that I was doing advocacy, I'm telling you, I'm saying the same talking points that I did 20 years ago, and I'm done with it. And I'm like, you know what? We got to do something different. So when Dr. Lisa Graybear said this to me on the podcast, like, you know what? We have been, for the last 45 years, we have been giving people money. We should try something different. Let's give it to other groups. Let's give it to the telehealth companies. Let's give it to home health. Let's give it to EMS. Maybe they can service a little bit better, because she had stats that she was giving out, because, you know, she really understands the Medicare payment policy world. That's where she geeks out. I kind of geek out a little bit too when we start talking about it. But she was saying less than 20% of all inpatients, less than 20% of all the beneficiaries that are Medicare beneficiaries, Medicare Part B and Part C, do inpatient stays. And so we were kind of going through the math. Like, she was like, the math isn't math. And all of us economists talking, like, we just don't see all these hospitals going out of business with all these dramatic changes. And so I'm like, okay, that's an interesting thought. I don't deal in the hospital world, so it doesn't really matter. I'm listening, but not really listening. But I'm just hearing protect and preserve, or adapt and innovate. And data is now going to require us to adapt and innovate. And there's one thing that the Department of Government Efficiency did, or DOGE, did, that Elon brought in with the team, was really being able to look at all the data and find nuances in the data. And you mentioned there is waste in healthcare. We should be honest with ourselves. We know there is waste. I know there is waste. I see it. So I think first we admit there is, that it's going to require us, though, to change. And change doesn't come at the same pace to everyone. And so if I could ask you one question about the EMS sustainability piece, in your mind's eye, what should we prepare for in the next 6 months to 18 months around EMS sustainability? What should we be looking at? If you're a fire department chief right now listening, or you're a private ambulance CEO listening right now, what are those things that they should be thinking about regarding EMS sustainability for the future?
So I think near term, it starts with understanding your data, getting an understanding of your outcomes, understanding what your quantifiable impact around value looks like. I think the conversation is a little different depending on what type of organization you are, where your mission calls you to serve. Are you in a rural community? Are you in a large urban area? How are you subsidized today? Are you a for-profit, revenue principally driven organization, or are you more of a volunteer or tax subsidized organization, right? So it looks a little different across the spectrum. I think there are tremendous unlocks that will naturally declare themselves as a result of not only the data, but the transparency that is coming, whether we like it or not, across all parts of healthcare. And transparency can be scary. Transparency can be sobering. It also creates a tremendous amount of opportunity for those that are willing to embrace that opportunity. We know that there are perverse incentives in healthcare to do things that don't make sense for the patient, that aren't good care, that generate cost for whoever's paying the bill. We also know that there are ways to innovate new delivery models, new care pathways. And in fact, EMS is incredibly creative. And the expertise that we have, because we're all hazards and we respond to unknown situations every day, there's an inherent ingenuity in our industry that allows us to think about these problems in ways that other parts of healthcare quite frankly can't. They're inside of four walls, and it's hard to be creative and innovative when you have that kind of a constraint around your thought process. So I think the real opportunity is for us to lean into our ingenuity, to lean into our creativity, to get honest with ourselves, looking at the data, specifically the outcomes data, and to say, where do we have an opportunity? An opportunity to improve, an opportunity to reduce waste, an opportunity to rethink modern EMS.
And you know what? You made a statement, and it's just very, very interesting to me. I'm having a flashback here while I'm listening to you to a podcast that I just did with Dr. Montes. And I asked him a similar question, and he responded with, and I'm paraphrasing what he said, you can go listen to the podcast, but it was like, the problem with it is EMS itself sometimes. Is sometimes we can't get out of our own way because we're locked into something, but we are very creative when it comes to like patient care and adapting. But for some reason, when it gets to some of this, it's always some local issue of why we can't do something. But we all know if we really wanted to do it, we'd fix the local issue to make it happen. Does that make sense? And so it was a very interesting concept when he said it. It was very direct, and I liked that conversation because he's a lot like me. It's just sometimes we don't have a problem putting it out there and having that honest conversation that we do need to have. So I respect what you're saying here. Well,
and let's normalize it. It isn't unique to EMS, right? I'm also an emergency physician. I'm also a recovering hospital administrator. We have the same pattern for all industries, and EMS is our own. And there's an opportunity there, and it's for us to seize.
And right now is the opportunity.
Yeah, things are moving very fast. And, in some ways that's driven by technology and what that's doing to change the game. Some of it's being driven by the administration and, kind of their pace for change. Some of it is also the necessity. We've been in a system that's unsustainable for a long time. And, the wheels do come off at some point. The creativity, the opportunity to solve the puzzle is there for those that want to lean in now. Now is the time.
So we're gonna wind up this podcast, but I'm gonna ask you one question, and I like asking this question of everyone, and I think I asked you on the first one, but I'm gonna ask you again that if there was no barriers, no impediments, no red tape, no government, and it was just all about healthcare, what would be the one thing that Eric Beck would do if he could impact and do anything that he wanted to in the healthcare continuum? You can only name one. What would that one thing be?
I wish that we paid for outcomes.
And that is the concept around disconnecting
the payment. Basically, when we link payment to outcomes, it requires the quality metrics, the delivery mechanisms, the incentive alignment, the interoperability, the cooperation to work upstream. Now, you can't go from current state to pure outcomes, right? There's a journey, and all the things we talked about, all the strategies that have been tried over the decades are part of how you get your way there. They do it differently in different parts of the world, and that isn't right or wrong. We have the system we have today. But leaning into outcomes, I think, is the real game changer for us, and linking payment and financial incentives to outcomes is fundamentally the unlock that creates a lot of derivative change for good.
Well, Dr. Beck, I want to say thank you for coming on here. Keep leading change. Keep leading forward. Keep leading into the uncomfortable. That's the only way that we change, is to have these conversations like we're having now. So thank you for joining me today.
I appreciate you provoking the conversation, Asbel, as always, and thanks for having me.
Absolutely.